on behalf of Cambridge Health Tech Institute's Global Web Symposia and our sponsor for today's event, Biomodels Conference, I'd like to welcome you to Irritable Bowel Syndrome, Utilization of Experimental Colitis Models to Transition Novel Therapies from a Concept to Patients. I'd like to introduce our speakers for today. First is Adam Shafitz. He is the director of the Center for Inflammatory Bowel Disease at Beth Israel Deaconess Medical Center, and also an associate professor of medicine at Harvard Medical School. Our second presenter today is Gregory D. Ling. He's the director of research for Biomodels, and he has come to Biomodels to work on their disease models. He received his PhD in biomedical sciences from the University of Albany School of Public Health and his Bachelor of Science in Neuroscience from St. Lawrence University. Our third speaker is Deborah Hartman. She's the Vice President of Research at Avaxia Biologics Incorporated. She leads the research team there at Avaxia in the discovery and development of orally active bovine polyclonal antibodies for the treatment of inflammatory bowel disease, gastrointestinal acute radiation syndrome, and other indications. Before joining Avaxia in March of this year, Dr. Hartman led a pharmaceutical research team at AstraZeneca, which delivered candidate drugs into clinical studies in multiple therapeutic areas. We have some very well-qualified presenters. So with that, I'm going to move the presenter ball over to our first presenter today, Dr. Adam Shafitz.
Thank you very much. I will take care of the clinical aspects of the program. Just to throw up some of my conflicts of interest or potential conflicts of interest, which shouldn't enter too much in today's program. The topic of today's program is inflammatory bowel disease, which is really, for the most part, made up of two main diseases, Crohn's disease and ulcerative colitis, although there are about 10% of patients which, despite an extensive workup, we have a hard time labeling, and we'll call them an indeterminate colitis or IBD unspecified. There are a number of other colitides that do fall under the idiopathic inflammatory bowel disease, but those are beyond today's scope. So IBD is not uncommon. It occurs over 1.2 million people in the United States alone, equally divided between Crohn's disease and ulcerative colitis, although the incidence of Crohn's disease has been increasing over time. Approximately 10,000 new cases are diagnosed annually in the United States. It is also becoming more common worldwide. Still the highest incidence is in North America and Western Europe, although we're seeing many more cases in Asia as well. The disease can occur at any time point, although it does tend to occur around late adolescence and early adulthood. The mean age of diagnosis is 30, although 1/4 of the patients are diagnosed as a teenager or younger. Disease does not discriminate between men and women and is equally prevalent in males and females. The pathogenesis of inflammatory bowel disease is not exactly known. It does appear to be an interplay between the genes, the environment, and the immune system. Currently, it's believed that in a genetically susceptible host, there's a change in the luminal bacteria that will then lead to an overactive immune response, although that is still being worked out. And right now, most of the drugs are really looking to affect the overactive immune response. So just briefly, ulcerative colitis is the more simplistic of the two diseases. It only affects the colon, and hence its name. It actually starts in the rectum and works its way forward proximally throughout the colon. It only affects the inner lining of the intestine called the mucosa, and it tends to be a continuous process. Almost all patients present with bloody diarrhea, and they will often have some abdominal cramping as well. Most of the patients seen in the community tend to present with more distal disease, proctitis, or left-sided colitis. Crohn's disease is the more complex of the two diseases. It can actually affect anywhere in the GI tract from the mouth to the anus. Most of the patients are affected in the ileum and the right side of the colon, but another third of patients will have perianal disease as well. As opposed to ulcerative colitis, this disease tends to be more patchy and is comprised of skip lesions, and most importantly, it can affect all the layers of the bowel wall, and that is what causes the various symptoms and presentations that patients with Crohn's disease can have. You can see here most patients actually present with inflammatory symptoms, nausea, vomiting, they can have abdominal pain, diarrhea. But over time, the disease progresses to be either more stricturing, where patients can get small bowel obstructions, or penetrating, where the luminal contents can spill into the abdomen, creating abscesses or acute appendicitis-like presentations in some, and they can also cause fistulas or connections between the intestines and other parts of the body. It's really the stricturing and the penetrating complications that lead to the really high rate of surgery in patients with Crohn's disease. Most studies will suggest somewhere between 60 to 80% of patients with Crohn's will require surgery within the first 20 years of the disease, and a lot of these really occur within the first 5 years. One of the big issues, as you can see on this slide, is that surgery is not curative. About half of the patients by even 5 years will have a recurrence of symptoms, and by 10 years, upwards of 20% of patients will have another surgery. Ulcerative colitis, over the course, about 10 to 15% of patients will require surgery to remove the colon. The course of both of these diseases tends to be one of waxing and waning remissions, period of feeling well in between periods of flare. The diagnosis is really clinical, although it often does require a gastroenterologist to do a colonoscopy. In addition, most of these patients will have small bowel imaging. Here I just showed some pictures so you can get an idea of some of the severity of the disease. And you can see on the left, with ulcerative colitis, it does tend to be more diffuse, whereas on the left you can see more discrete ulcerations. You can really see some good deep ulcerations, linear ulceration in the bottommost right area. It's an exciting time in the field of inflammatory bowel disease, certainly over the last 15 years, and each year I'm in it, there's more and more that we learn, but more and more that we don't know. Even the goals of care have really changed in the last 5 years in particular. Once a diagnosis is established, really, for the longest time, all we talked about was inducing a clinical remission and then maintaining a clinical remission, meaning you get the patients to feel better, and once they feel better, you try to keep them feeling well. Nowadays, in addition to clinical remission, we really do start talking about the potential benefits for endoscopic remission. And there are some patients, we still need to define this better, that we will aim for endoscopic remission or endoscopic healing as well. There is some preliminary data that patients in endoscopic remission will actually do better, and we may be able to prevent hospitalizations, try to prevent surgery, and avoid the complications that lead to the hospitalizations and surgery as well. If we can do all this, we really can improve the patient's quality of life. Really what we'd like to show is that we can eventually alter the natural history of the disease and really prevent the damage to the organs. This is a slide that shows the traditional therapeutic approach to inflammatory bowel disease, what we term sometimes the step-up treatment paradigm, where in the past we've started with the medications that maybe don't work as well, but they tend not to have as many Side effects, failing those, patients would go up to corticosteroids, the immunomodulators, the azathioprine, methotrexate, 6-mercaptopurine. Failing those, oftentimes they would save the anti-TNF therapies till the end. Natalizumab, also often saved towards the end for anti-TNF failures, and in general, physicians and patients would really attempt to try to avoid surgery in their patients because in Crohn's disease, it really is not curative. In recent years, we've much more started talking about flipping this pyramid upside down, getting more aggressive early, particularly with the anti-TNF therapies, hopefully preventing the damage, treating the inflammation, and preventing the damage ahead of time before it can lead to the penetrating and the stricturing complications that lead to surgery. Some people call it top-down. Another area would be sort of accelerated step-up therapy. The treatment of ulcerative colitis, as it is a somewhat more simplistic disease, is also a little bit more algorithmic, although it may not look like that from this slide. Patients who present with more mild to moderate disease, most of these patients will do well on the oral or rectal mesalamine therapies. I tell the patients to think of it almost as a topical aspirin. These will work topically. Very little of these drugs are actually absorbed. If they fail the mesalamines, oftentimes they will end up on oral or rectal corticosteroids. I put in budesonide MMX because that was recently approved and is a more topical corticosteroid with less side effects than systemic corticosteroids like prednisone. Those patients that responded to oral steroids oftentimes are placed on azathioprine or 6-MP, thiopurine immunomodulators. Failing that, oftentimes patients who aren't hospitalized would then go on to an anti-TNF. There is some debate now whether anti-TNFs should be used earlier in the course of the disease, certainly sometimes in lieu of azathioprine, and in patients with contraindications to corticosteroids, you can use the anti-TNFs even earlier. I'll skip the right side of the slide, which is really talking about a very sick patient population that fails oral steroids and requires admission to the hospital. Crohn's disease is more complex to treat. Although the 5-aminosalicylates are still probably the most commonly prescribed drug, there is very little to no evidence that they are useful in inducing remission and really no evidence they maintain remission. Antibiotics can be used for the suppurative complications of Crohn's disease when you have the perforations or abscesses, and there's some data that can be used for perianal disease, but really no data on the luminal Crohn's disease itself. Corticosteroids, although they work very well, they come with a lot of potential toxicity, and there's really no evidence they maintain remission in either Crohn's disease or ulcerative colitis. The other medications, the immunomodulators, azathioprine, methotrexate, they are a little slow to induce remission, but good at maintaining remission. The anti-TNF therapies, they work quickly and can maintain remission, similar to natalizumab, which is excellent at maintaining remission. I think has a slightly slower onset of action. Really, the biggest change in our treatment of inflammatory bowel disease really started back in the mid-1990s when this study by Steph Targan was done that really showed infliximab, the first anti-TNF chimeric monoclonal antibody, even after one dose, really put half those patients who'd failed other therapies into remission, which was remarkable. There have been many studies since then, I'm not going to go into any of them, that really show it's effective for Crohn's disease, fistulizing perianal Crohn's, moderate severe ulcerative colitis, pediatric patient populations, some of the extraintestinal manifestations, including pyoderma gangrenosum and uveitis. It's been shown in secondary endpoints to decrease the need for steroids, improve quality of life, and at least in the short term, meaning about a year or so, decrease the risk of hospitalizations and surgeries. It's not a panacea. if you really want to take a pessimistic view of these types of medications, really when you look at 1 year of all those patients started on an anti-TNF, only about 25% of those patients are in remission and off of steroids. So we still, I think, have a long way to go. This is probably one of my favorite studies in inflammatory bowel disease. It was really one of the first comparative effectiveness trials looking not just at a medication versus placebo, but looking at different ways to treat patients. And here you can see patients that got the combination of infliximab plus azathioprine did better than those patients that got just the infliximab in yellow, and even better than those patients that got just azathioprine in the red. And this was the same for clinical remission, clinical response, and even endoscopic healing. Since then, mid-1990s, there have been multiple other medications, anti-TNF, approved for both Crohn's disease and ulcerative colitis, the most recent being golimumab, approved for ulcerative colitis. For the most part, the efficacy as well as the toxicity appears relatively similar across the different medications. It's really the mechanism of action that tends to be different. Why isn't everybody on the anti-TNFs? It's because of the risk for potential toxicity. We worry most about infection, including fungal, bacterial, tuberculosis, reactivation of hepatitis B. There's some question out there about whether these drugs cause lymphoma. Certainly the combination of azathioprine and anti-TNF increase the risk of lymphoma. It's still, I think, unclear whether monotherapy with an anti-TNF leads to lymphoma. Melanoma and other skin cancers are a risk, and some very rare multiple sclerosis, heart failure, very rare. Antigenicity or immunogenicity can be seen with any of the antibodies, which can lead to early loss of response, as well as infusion reactions in the infusibles. I will touch on Tysabri as it's the other biologic approved for Crohn's disease. It's effective, as I mentioned, in inducing and maintaining remission, and it looked very good for those with particularly TNF failures. The problem with this drug is early on it was seen that there were 3 cases of a very rare brain infection called PML, which is almost universally fatal. It was withdrawn off the market, brought back first for MS and then brought back for Crohn's disease in 2008, but only approved for monotherapy, and the patients need to be closely monitored. The risk of PML was determined to be about 1 in 1,000, but very recently they came up with a JC virus antibody test, which is very good at risk stratifying patients. So if you do not have the JC virus antibody, your risk of PML is pretty close to non-existent as long as it remains negative, whereas your risk of this brain infection, if you are positive for the virus, is upwards as much as 1 in 125 after 2 years on the drug. The problem is about half the population has been exposed to JC virus. As I mentioned, it's an exciting time in IBD, which sometimes make it difficult to treat as there's many unanswered questions relating to who we treat, how we treat them. Are we aiming for deep remission, clinical plus endoscopic remission? Are we treating to drug levels now that they're available for some of the anti-TNFs? Should we be using concomitant immunomodulators with our anti-TNFs? How early should we be using them? Can we ever stop these? Really, how safe are these in the long run? And most importantly, are these drugs going to affect the natural history of IBD? Are we really preventing hospitalizations or surgeries, or are we just postponing them somewhat? There's numerous areas of current research, other new anti-TNFs. One of the more, so there's ustekinumab, phase 3s are out on. One of the more exciting ones hopefully coming out will be vedolizumab. It's another selective adhesion molecule inhibitor, similar to natalizumab or Tysabri, but gut-specific. JAK inhibitors, multiple companies are looking at those, including tofacitinib. All the patients want to hear about Trichuris suis, which is the pig whipworm. And rifaximin, there was a recent study. It's a non-absorbed antibiotic. And the other one patients all want to hear about is fecal or stool transplant. But there's many other drugs being looked at, but I will end there.
Thank you very much, Adam. And now we're going to move on to our second presenter, Gregory Ling.
Thank you. And thank you, Adam. That was a great clinical overview of the disease. I think it gives people a really good perspective as we move forward and change the focus of the talk today a little bit now to the drug development process and some of the preclinical models that can be used to develop therapies and new therapies for IBD. So to start, I'm just going to give a little overview of Biomodels and what we do here. Well, we are a preclinical contract research organization. We're located in Watertown, Massachusetts, just outside of Boston. And we were originally founded in 1997 as an offshoot out of the Brigham and Women's Hospital. The Brigham was actually an equity owner in Biomodels up until a year ago or so. Our company focus is on highly translational models of human diseases. And as we'll see today, our real approach is taking a collaborative approach with both our clients and client scientists and involving the clinicians that are of importance and the scientists involved in each of these projects throughout the entire drug development process from concept to patient. That, really our goal is to transition these drugs or biologics that come in our door as a concept or as a new molecule into patients for therapy. And as a success story to that, to date, for a small company as we are, we have facilitated over 28 compounds that have entered here that have now been in patients. Our therapeutic expertise really lies within the diseases of inflammation, fibrosis, supportive cancer care, oncology, metabolic disease, neurology and psychiatric disorders, as well as genomics and the analysis of genomic data. So I think when we think about animal models in general and preclinical drug development, I think everybody's looking for the perfect animal model for any indication or any disease. And while there's never one perfect model for most indications, I think our description of what we'd like to see in animal models is important and I think should be considered when we're talking about this. Basically what we hope for is that a model must replicate the clinical condition, that the endpoints that we use to evaluate these models in the disease state must be translatable to those that are used in clinical trials and easy to interpret. Ultimately, the underlying biology should also be as similar or the same as it is in humans. And the model must be cost-effective and provide actionable information for which you can make decisions on whether or not to proceed with the drug in development. So IBD is one of the biggest areas that we work in here at Biomodels, and with that, we offer a number of animal models that have very kind of different induction processes and different severity and different durations. Today, I'm going to focus a little bit more on the top few here, the DSS and TNBS models, but wanted to give a general overview of the other models that we're working with and where we're headed in terms of our IBD research. So if you look at the top of the list here, the DSS-Induced Colitis models are some of the most popular models that we run. The acute chronic model that we look at here is basically a single administration of DSS from day 0 to 5, and we end up with colitis severity peaking on day 10 and persisting out through day 21. So these are kind of acute to semi-chronic studies as we put them and last 10 to 21 days typically. We also have a model of DSS-induced colitis that is more chronic in nature and can go out 35 or even 42 days, where we administer DSS in repeated cycles at a slightly lower concentration. Here you can see clinically persistent disease from starting on day 11 and persisting out through the study conclusion. The TNBS-induced colitis model is another chemical model, and this can be done with or without pre-sensitization depending upon the cell types that are wish to be involved. But generally speaking, it is a relatively acute disease and is administered through intrarectal administration as opposed to the DSS, which is a systemic administration. Here, disease peaks on day 3, persists on day 5, and interestingly is almost completely resolved by the time out to day 12. Another model that's very similar to TNBS in the time course of the disease and the method in which it's administered and induced is the oxazolone-induced colitis model. This is probably one of the trickier models that we run in terms of disease consistency and disease severity, but it has some similar properties to TNBS in the fact that it's acute duration and lasts only 3 to 5 days. So those are models that we run very consistently. And the bottom of the list here are models that we are currently developing and have some preliminary data on in some cases and are still in the development phase in others. So the first one is the CD40 monoclonal antibody-induced colitis models. This is basically a CD40 agonist, and it is administered IP, and the animals will develop pretty severe colitis by day 3 that's supposed to persist to day 7. As I mentioned, this is under development right now, but we do have some pretty good preliminary data to support the efficacy of this model and with some control compounds. Another model that we've been focusing on very heavily over the last few months here at Biomodels is the adoptive transfer model. The approach that we are taking is the isolation of CD45 RB high T cells and transferring those into RAG2 deficient mice. This model has some tricks of the trade, I would say, and typically what we could expect to see is development of disease within 6 to 8 weeks. At that time point, animals begin to lose weight and develop progressive colitis. We're currently on our second attempt at this model, and we've tried to troubleshoot as much as possible. I think we're in a very good position now moving forward and hope to have some better data and some kind of confirmatory data here within the next couple of weeks. And the final model that we are in talks with a few of our collaborators on is the IL-10 knockout. The IL-10 knockout is kind of traditionally an academic model, but there we are able to obtain the license for this. One of the advantages to this model, I think, is that it's even though it's a genetic model, it can be synchronized with onset. So while typically these animals would develop spontaneous colitis after 3 to 6 months of age, we can obtain the animals at 6 to 8 weeks of age and use an NSAID such as piroxicam to synchronize the onset of disease and really shorten the cycle of the model. So for any of these models that we use, our endpoints are pretty similar. One of the main endpoints that we use, and I'll talk about a lot and we get into additional slides, is video endoscopy to evaluate the colitis severity. But more traditionally, we record body weight daily, the presence of blood and diarrhea in the stool, colon weight and length, and histopathology. Additionally, the tissues that are obtained from these models can be used for any sort of ex vivo analysis that you can really think of. So as I mentioned, one of our primary endpoints in these models is video endoscopy. And truly, and as kind of Adam alluded to earlier, the real goal of IBD therapies is to show mucosal healing properties. And I think that the addition of the endoscopy, which will allow us to track disease in a real-time manner, will show that, going from animals with diseased colons to animals with more normal-looking colons. And what this has also added to, in terms of the animal model usage, is that traditionally animals had to be sacrificed at each individual time point. Now we're able to track the same animal multiple time points throughout the course of the animal model and the disease state. And it really provides for much more powerful data and a longitudinal assessment. As you can see over here on the right-hand side, and you'll see some more of these images as the presentation goes on, the images from the rodent to the human, while there's some differences obviously in the overall color of these images, the disease presents pretty similarly in terms of ulceration, bleeding, inflammation, edema. You look at these normal samples, you can see the vasculature pretty clearly, but as the disease models, as the disease advances, some of the changes look very consistent. Another advantage to this method is it's pretty easy to do in terms of animal health and in terms of the longitudinal assessment. So this is a basic procedure that's done under inhalation anesthesia. Obviously, with a lot of practice, it can be a little tricky, but we also have the ability to do things such as biopsy. Not in mice so much, but in rats and in other models where we may have colorectal cancer, we can take actual biopsies and use biopsy forceps through the working channel in our endoscope. So when we first started working with the endoscope and IBD models, we really wanted to ensure that the endpoints that we were obtaining were relevant and correct. So we did a lot of work to evaluate the disease models, especially in TNBS and DSS, to ensure that the histopathology and the results that we were getting endoscopically correlated. As we can see in these images, while the disease severity may not be one-to-one in correlation, the general trends of disease correlate very, very well. And as we start to see some of the data that I'll present, the changes in disease state associated with positive control therapy, the correlation between endoscopy scores and histology scores are very, very robust. So to get into a little bit more detail about some of these particular models, I'm going to talk about the DSS model to begin with here. And this is the acute semi-chronic model, where DSS is administered from day 0 to 5 at a 3% concentration. Typically, we do endoscopy evaluation here on day 7, 14, and 21, but can also add in other time points. The way the disease progresses is we get chronic colitis that begins around day 10 and persists out through day 21. At the conclusion of the study, we always conduct a final endoscopy. Obviously, as I mentioned, body weights, incidence of bloody diarrhea, colon length, colon weight, and histopathology. I think what's really interesting is we look at the data from these models. So in these two figures, what we've presented here are untreated control, DSS control, and a DSS plus prednisolone, which is a kind of a common comparator molecule that's used in many of our studies. What you can see is that the animals will very, very consistently result in peak weight loss between day 8 and day 10. Well, what's really interesting is that these animals regain most of their body weight by day 20. Prednisolone is usually, at the doses we use, is somewhat catabolic, so the prednisolone is usually lower than the vehicle control. However, when we look at disease severity here, with endoscopy scores on this axis and time on the other, we can see that endoscopy scores will show that there's mild to moderate disease by day 7, peak disease by day 10, and persistent disease out through day 21. Now, if we were just looking at the weight data here, we would think that, the colitis is probably recovered by day 21. But in fact, the disease does persist at a pretty high level. And as we look at the prednisolone data here, this is, I think, probably a good result for prednisolone. It doesn't always work this well, but you can see, 25 to 30% reductions in colitis scores at peak severity, which is a pretty robust result in this model. Since we're always looking for more positive control data in these studies, we currently have a couple ongoing studies looking at 6-thioguanine as well as some of the biologicals such as Humira that may be a little bit more clinically relevant in terms of positive controls. But we do have experience with both small molecules and biologics on many levels. Another model that's a very common chemically induced model is the TNBS-Induced Colitis model. As I mentioned earlier, this can be done with pre-sensitization on the skin a week prior, or it can just be done in an acute setting with an acute intrarectal dose of TNBS on day 0. In this model, animals are evaluated via endoscopy on days 3 and 5 post-TNBS challenge. Disease usually peaks between day 3 and 5, and it's pretty similar between those 2 days. And as I mentioned earlier in some of the images that we saw, it resolves pretty much completely by day 12, so it's definitely a very acute study. The data that I'm showing here is simply a dose response of TNBS. So what we're seeing is weight loss induced by TNBS administration on day 0, and what we can do is very much modulate the disease severity depending on the TNBS dose that's administered. The higher doses result in much more severe weight loss and persistent decline, whereas the lower doses result in a very similar acute weight loss, but a much more rapid increase in body weight. And as we look at the endoscopy scores, we see very similar trends. Ideally, what we're hoping for in any of these animal models is to get moderate to severe disease, but disease that you can modify in either direction, either making it worse or making it better. So when we look at the comparison of these two models, I think this is since these are the two most commonly models used, I think, in IBD development at this stage, I think it's important to look at the pros and cons and the differences between the two of them. As we look at TNBS, as I mentioned, weight loss in colitis is acute, peaks 2 to 3 days following the administration, and is transient in nature. And you can see this in these images here where we have controls on day 0, very robust disease endoscopically on day 3 and day 5, but by day 12, it looks virtually the same as control. When we look at the DSS model, the control on day 0 is very normal looking. As we get out to day 7, you start to see some edema and some inflammation. As we get to day 12 or around peak, we continue to see some bleeding and some friability. And as we get to day 21, you still have this maintenance of edema, inflammation, and some minor bleeding. One of the interesting things to note, though, is when we look at the histopathology. The histopathology in the TNBS model, the changes are relatively minor compared to that of DSS. There tends to be more of a superficial sloughing of the epithelium, bleeding, but the depth of the penetration of the disease is not nearly as great. The inflammatory infiltrate that's there is not as severe, and the mucosal ulceration that's there is less severe too, especially if you compare peak disease on day 3, which is a relatively normal-looking tissue section, to that in the DSS model where most of the structure is completely gone, large amounts of edema, large amounts of necrosis, and large pockets of inflammatory infiltrate. And I think having the understanding of the disease biology in terms of what the response is in terms of inflammation and then the mechanisms by which this occurs, these models can really be used to, we can do a lot to predict which models are most appropriate for individual therapies. So I think that, having a variety of models to use is a good thing in that way. As we look at, not having the perfect animal model, that can be a little bit of a challenge, but I think knowing that there are so many available and picking and choosing the ones that are most appropriate for your compound is a very good approach. Finally, I'm going to wrap up here with some chronic DSS data. This is a model validation data set that we looked at, looking at a number of positive controls. And this is in the model that does repeated cycling of DSS. We conducted endoscopy on day 10, 20, 27, and 34. And we basically dosed all therapeutically, so starting on day 10 as opposed to prophylactically. We use prednisolone, cyclosporin A, and 6-thioguanine as controls here. And you can see in the weight curves, after the first cycle of DSS, you don't see much weight loss, but after the second cycle, you see very profound and continued weight loss. Once again, the prednisolone weight loss is more severe than the other treatments, and including the control. Interestingly, there's no beneficial effect on weight change by any of these therapies, and we'll see that as we get closer to the endoscopy scores. That's not necessarily the case there. The graph on the left here shows basically the consistency of the disease throughout the model. You can see that there's a persistent elevation in colitis in the control groups. As we start treating on day 10, all of the groups are pretty much the same in terms of disease severity. And as we get out towards the end on day 34, you just start to see some real separation in the treatment groups. And I think this is important because this model allows for a very long time of dosing. So instead of trying to force a drug to show efficacy in 3 to 5 days, this model allows your compound to be administered for 3 to 4 weeks and really allows the mechanisms to become involved. And if we look at the endoscopy colitis scores on day 34, you see a nice robust involvement in the vehicle group and a significant reduction in disease state with prednisolone, cyclosporin, and 6-thioguanine, with 6-thioguanine being the most consistent over the duration of the study. But as I mentioned, when we look at the weight versus the endoscopy scores, it's always important to choose the right endpoint, because if you were just focusing the study on weight change, basically would say that nothing worked. However, when looking at the endoscopy scores, it's pretty obvious that the compounds did work. And this is a little bit closer look at what the endoscopy scores looked like at that time, with the DSS being normal, the vehicle showing very profound disease with active bleeding, and the treatment groups all showing much less bleeding, much less inflammation, and much less involvement in general. To wrap this up, we also did histopathology, and as I mentioned earlier, the histopathology correlates quite nicely with that of endoscopy. Interestingly, the effects with the histopathology are always slightly muted compared to endoscopy, which we kind of take to be likely due to sampling effects that we see in histopathology, whereas we are able to sample the entire extent of the colon via endoscopy. Ultimately, though, these are pretty robust endpoints and I think are very important for continued development. So with that, I'd like to transition this over to Dr. Deborah Hartman from Avaxia, and Debbie can give a description of how Avaxia and Biomodels have worked together over the past few years and has led to the successes that Avaxia has recently experienced with their IND.
Thanks very much, Greg. I'm happy to have the opportunity today to present some of the work that we've done in collaboration with Biomodels, as Greg has said, to support our lead clinical candidate, AVX-470, in the development for inflammatory bowel disease. So Avaxia Biologics is a clinical stage biotechnology company with a strategic focus on gut-targeted antibody therapeutics. And this uses a platform that provides a platform that can address any target accessible from the lumen. Avaxia leads in gut-targeted antibodies with the only orally delivered antibody in the clinic. And our lead clinical candidate is AVX-470, which is an oral anti-TNF antibody, currently in a phase 1b study in patients with active ulcerative colitis. Avaxia was founded in 2005 by CEO Barbara Fox, and we're located in Lexington, Massachusetts. The technology, which is wholly owned by Avaxia, allows for development of orally administered, minimally absorbed drugs that act locally in the GI tract. The Avaxia platform consists of polyclonal antibodies from bovine colostrum. And these antibodies can be orally administered because they are naturally resistant to digestion. Their protein stability has been demonstrated even in clinical studies, as I'll show you on the next slide. Bovine antibodies are inherently safe. There's a long history of oral exposure in humans through the dairy and meat products that we eat. And bovine immunoglobulin has actually been labeled as generally recognized as safe, or GRAS, by the FDA at levels up to 30 grams per day. These antibodies act locally in the gut, and they stay in the gut with minimal systemic exposure seen in over 400 animals to date. Avaxia has a strong intellectual property position with 4 issued patents and freedom to operate in this area. Bovine colostrum antibodies have been shown to be resistant to digestion in humans, and this slide lists a set of Harvard studies that show clinical data demonstrating the stability of bovine colostral immunoglobulin in human GI tract. In one study, in ileostomy patients, 49% of the dose administered could be recovered in ileal fluid. And in other studies, in normal subjects, up to 33% could be recovered in stool. AVX-470 is a bovine colostral antibody being developed for inflammatory bowel disease. It is made from the colostrum of cows that have been immunized with human TNF, and it is formulated in enteric-coated capsules for release in the lower GI tract. This polyclonal antibody neutralizes TNF locally in the digestive tract. In collaboration with Biomodels, we've shown efficacy in mouse models of inflammatory bowel disease, which I'll show you in the slides to come. We've also demonstrated safety in mice, rats, and monkeys with minimal and only sporadic systemic exposure in these studies. This should greatly reduce the potential for side effects that have been associated with immune suppression of systemic TNFs, and thus may provide the opportunity for a safer anti-TNF therapy with the potential for first-line treatment in inflammatory bowel disease. This efficacy work that started at Biomodels has now progressed through to the clinic, and we are looking for early clinical results early next year. The in vitro characterization of AVX-470 has shown a picomolar binding affinity to human TNF and an ability to neutralize human TNF in the L929 assay. And this affinity and potency is similar to the anti-TNF monoclonal antibody infliximab. TNF is a clinically validated target for inflammatory bowel disease, and we were lucky to have well-characterized models available for TNF-mediated pathologies. These include the DSS and TNBS colitis models that were described by Greg. Because AVX-470 is a human-specific polyclonal antibody, we developed a surrogate antibody for mouse TNF to study in these models. This was generated by immunizing cows with recombinant mouse TNF and is called AVX-470M. And this is used in the studies that I'll show you in the subsequent slides. We characterized the affinity, potency, and specificity of AVX-470M, of course, and showed it comparable to AVX-470. One potential confounding factor in translating from mouse to human for an oral antibody is the possible interaction of that antibody with the neonatal Fc receptor that may be in the intestinal tract. The FcRn mediates transcytosis of immunoglobulin across the intestinal epithelium. For bovine colostral antibodies, however, this is not an issue because bovine Ig does not bind to the human FcRn, and in mouse, there is no expression of the neonatal Fc receptor in the adult GI tract. Therefore, this allows a direct comparison between human and mouse models. Greg has already outlined the use of endoscopy as an important and clinically relevant endpoint for IBD models. We have used this endpoint in characterizing the in vivo activity of AVX-470M. In the DSS colitis model, which is believed to model ulcerative colitis in particular, AVX-470M was shown to reduce disease severity as measured by video endoscopy. In these studies, C57 Black 6 mice received 3% DSS, as Greg described, for 5 days, and this was then followed by dosing of AVX-470M by oral gavage twice a day from days 6 through to day 19. And on this slide, the video endoscopy scores are shown, taken at day 12 and day 19 in the same animals. Animals treated with saline had endoscopy scores up to 3.5, and treatment with AVX-470M at 10 milligrams per day reduced that score down to 2 at day 12, and even further down to 1.5 at day 19. And you can see at day 19, we also have a lower dose of AVX-470M, 1 milligram per day, showing activity. In this model, prednisolone was used as an active positive control, and this was dosed orally at 1.5 milligrams per kilogram. In this experiment, in parallel, we showed that TNF and related inflammatory markers were upregulated in the colon of mice with colitis by immunohistochemistry and RT-PCR, and AVX-470M downregulated expression of these cytokines and markers in this model, consistent with the reduction of the endoscopy score. In addition to prednisolone, shown on the last slide, Biomodels had also worked out the conditions to measure efficacy of etanercept in this model as a key TNF neutralizing benchmark compound. And in this study, you can see AVX-470M was effective at both the 10 and 3 milligram per day doses, given again by oral gavage BID from days 6 through 19, and this was an efficacy that was equivalent to etanercept. In a third study then, AVX-470M was also shown to be effective in the TNBS-Induced Colitis model, which is believed to be a model of Crohn's disease. In this model, animals were administered TNBS intrarectally at day 0, and AVX-470M was administered by oral gavage starting either 12 hours before TNBS treatment and administered through day 3. And this shows endoscopy on day 5. Animals treated with saline had endoscopy scores of 2.5, and these were reduced down to 1.5 with 10 milligram per day AVX-470M. Shown on this slide and in the previous 2 or 3 slides is also a negative control that we used, which is control immunoglobulin. Control immunoglobulin is purified from cows that were not immunized with TNF, and therefore it has no anti-TNF activity, and in these models is therefore not active as expected. In all of these models, Biomodels performed necropsy and tissue preparation to enable the parallel determination of key biomarkers and histopathological analysis, as I've described. This slide summarizes our data in the mouse IBD models. We have seen a statistically significant decrease in disease severity across 4 experiments, with a % reduction in disease severity up to 30%. And this provided strong evidence of preclinical efficacy using a clinically relevant endpoint. We based our dose selection for the phase 1 clinical study that is ongoing on allometric scaling from this data. In summary, AVX-470 is an orally administered anti-TNF antibody that acts locally in the gut with minimal systemic exposure, and this may allow for an improved safety profile compared to systemic anti-TNFs, and therefore may allow for earlier intervention in the disease. Our in vitro data have demonstrated comparability of affinity-purified AVX-470 with infliximab for both binding and potency. And in collaboration with Biomodels, we've demonstrated efficacy in both DSS and TNBS-Induced Colitis models, comparable to prednisolone and etanercept, key benchmark compounds. This data was key to enabling our IND, which was submitted last year, and we now look forward to clinical data from our ongoing phase 1b study, with top-line data expected in early 2014. Thanks very much. I'll end there.
Thank you very much, Deborah. With that, I'll turn the question and answer period over to Wendy Sauer, who will be moderating the questions.
Great, thank you. This is actually Greg once again. I just wanted to say thank you to Adam and Debbie for joining us today and helping with this. And just in closing, I think looking at the animal models that we've discussed and looking at the data that we've discussed, I think our goal from Biomodels' perspective is to just assist more companies like Avaxia in this process. I think that having the clinical expertise, having the scientific expertise, and all working together from start to finish, from concept into the patient, is a fun process, and we look forward to addressing some questions and speaking with people further after we get off the conference call today.
Great. So I'll address the first question. Adam, one of the first questions was, what are predictable clinical biomarkers, immune response related, before the onset of ulcerative colitis or Crohn's disease? If not, are clinical diagnostics more typical of established disease?
It is. It's tough. There's only been one study that showed that some patients prior to the disease may be positive for ASCO or anti-Cerevisiae antibody. It was an Israeli study. Once patients have the disease, we do tend to try to follow some inflammatory markers. None of them are necessarily great. C-reactive protein is probably the best blood marker we have for sort of monitoring disease and disease activity, but there are 20% of people that, due to genetic differences, can't mount a CRP. Particularly in Europe, we're getting a little bit better here. They are starting to use a lot more fecal calprotectin, which probably seems like eventually it'll be the best sort of biomarker. Fecal lactoferrin is also another one. One of the issues with designing studies for Crohn's disease is that the FDA uses the Crohn's Disease Activity Index currently as the gold standard for response to drug. and the index is notoriously poor. It's very subjective and not necessarily objective, and we've shown issues with our own studies with that. But they are, I think, heading towards using using endoscopic changes, endoscopic healing as the new marker. Again, the problem with Crohn's disease is that the endoscopic scoring systems are extremely difficult to use and are really only used in large clinical studies to date. So the best would be a fecal marker for establishing the endoscopic healing. I'll leave it at that.
Great. Thank you, Adam. And the next question I'm going to direct is towards Greg. And I'm going to ask, this said, what is the scoring system used to rate the endoscopic assessments?
So kind of speaking to Adam, a little bit what Adam just said. So the assessment basically in the animal models is looking at the changes from a normal colon where you can see completely clear vasculature to basically what's a score of 0. A score of 1 would result in minor changes to the vascular appearance, inflammation, edema. A score 2 would result in some friability that's associated with the endoscopy itself. Score 3 is usually active bleeding in addition to all of those other aforementioned parameters. The score of 4 would be frank ulceration of the tissue. And that aligns pretty well, I think, with the clinical assessments that are done and has proven to be a pretty sensitive measure in terms of the data that Debbie shared and that we've shared with positive controls.
And then I'll ask one last question. This is directed toward Debbie. Debbie, have you identified efficacy biomarkers for this drug in humans or mice?
We are we've conducted a number of studies in the animal models, looking at a panel of inflammatory biomarkers, bioimmunohistochemistry and RT-PCR markers that, everything from following TNF through to other key inflammatory cytokines in these models, and we are also able to collect samples from the clinical study where we'll have some biopsy samples where we'll be studying those same biomarkers in the clinical study.
Greg, this question is for you. Can you provide some insight into the TNBS repeat cycle design? Do you have any predictive value on those?
Yeah, so we have actually worked with so basically the TNBS model is typically done as an acute intrarectal administration, but you can do it in a repeated type setting where you administer TNBS at different time points throughout the duration of the study in an attempt to obtain a more chronic disease state. Unfortunately, my personal opinion of the model is that it's several acute models that have just been kind of put end to end. Basically, what you get is a resulting, disease that's induced, then it recovers, and it induced and recovers. You may end up with some more long-term changes, such as fibrosis and kind of similar descriptive changes. But in terms of a consistent disease state, the most consistent ones that we see in a chronic setting are the DSS changes.
And one more question for Adam. What do you think about probiotics in general to induce remission and or to maintain remission? Do you have specific probiotics to recommend?
So the best data for the use of probiotics in inflammatory bowel disease is for the treatment of pouchitis, which is when patients with ulcerative colitis have their colon removed. They can fashion a neorectum with small intestine. That's called the J-pouch. Pouchitis means inflammation of that. So there's some data on preventing pouchitis, and there's some data on then preventing recurrent pouchitis with a probiotic called VSL number 3. It's 9 different bacterial strains of over, say, 900 billion bacteria. And the other data is for ulcerative colitis. Again, it's with VSL number 3. There's little to no data for probiotic use in Crohn's disease. And these are really for more mild to moderate cases. And the number of bacteria and the cost can be prohibitive, as most insurance companies won't cover the cost of probiotics, and can be upwards of thousands of dollars a year. But again, so the data is mostly for recurrent pouchitis and, inducing and maintaining remission in mild to moderate ulcerative colitis.
Thank you, Adam. And one last question, and this is directed towards Debbie. What is the half-life of the AVX-470?
That's a very good question. This is a unique drug. It is a polyclonal antibody that enters the gastrointestinal tract, and in cases where tissue is inflamed, we do see tissue penetration into the epithelial intestinal mucosa, and we see levels of antibody there persistent over periods of days. Further pharmacokinetic studies are ongoing in animals and in our current ongoing clinical trial as well.
There's an interesting question here about fecal transplant as a positive control. That's something that, speaking, as Adam mentioned earlier, that's becoming much more of a clinical question. We have not tried that to date in any of the colitis models that we've used, but, I think it's definitely a very interesting topic, and we are getting a lot more of our research here is being directed towards the changes in the microbiome. We've done some analysis of the microbiome using a company that we work with. And these, there are some pretty robust changes that can be observed. I think it's a data set that becomes very hard to interpret very quickly. It's kind of in the early stages, I think, and but I think the microbiome is obviously going to be the forefront of a lot of the research in IBD in the coming years. So I think it's a good question and something that ideally we'd like to be able to test here.
I have another question here for Adam. Are most cells involved in the pathology of ulcerative colitis and Crohn's disease?
I do not, I'll be honest, I don't understand the question exactly. It's the inflammatory cells, mostly the gut immune system that's involved in the pathogenesis, but it's still, exactly which cells and how, is still not exactly clear.
I mean, in the animal models, you'll see a lot of neutrophils and lymphocyte infiltration. But I think, like Adam said, I think that another question that alerted to T cell involvement, and there is evidence for T cell involvement in the more chronic models, the pre-sensitization model for TNBS, as well as the repeated cycling model of DSS, and much more so, obviously, in the adoptive transfer models where you're actually administering T cells to immunocompromised animals.
And I think that's it. All the other questions we do have documented, so we will reach out to everybody over the next 24, 48 hours and make sure to respond to all of the questions that were posted.
Thank you very much, Wendy, and thank you, Adam, Deborah, and Gregory. I'd like to thank everyone who spent some time with us today. Thank you for taking time out of what I know is probably a very busy day and joining us for this event. So with that, on behalf of Biomodels and Cambridge Health Tech Global Web Symposia, I'd like to thank you for attending today and wish you a very happy rest of the day. Good day, and thank you. Bye-bye.